are days at the office when you think or hope your cases will be routine and easy to diagnose. And those are the days that the universe ensures your day is anything but routine, and there are a good lot of challenges. Of course, we love a challenge, otherwise, we would not be pathologists and diagnosticians. Stay tuned for a healthy dose of challenging cases in Expecting the Unexpected, a day at the office with Dr. Narayana from our recorded lecture series. Hi, I'm Dr. Mandana Donahue, founder of Oral Pathology 360, where we help you stay updated and connected with everything and everyone in the diagnosis and management of oral and maxillofacial diseases. If this is your first time here, be sure to hit the subscribe and the notification bell so you never miss anything. You can also help support the work with you by contributing through the super thanks and super chat buttons which are there below every video. Coming to our amazing guest today, Dr. Nagamani Narayana is the professor in oral pathology, Department of Oral Biology, and the director of the Oral Biopsy Service of the UNMC College of Dentistry, Nebraska, USA. Dr. Nagamani began her career in India, where she completed a master's in oral and maxillofacial pathology. Subsequently, she also received training in oral medicine and oral and maxillofacial pathology from UMKC, School of Dentistry, Kansas City, and New York Hospital, Queens. She also has a DMD from Temple University School of Dentistry and is also a diplomat of the American Academy of Oral Medicine and the American Academy of Oral Pathology. With this short introduction, let's watch how her day unfolds at the office.
Good morning. I'm talking about expecting the unexpected a day at the office. Thank you, Dr. Mandana, for giving this opportunity to share my interesting cases. Here it is. Without much ado, here I am. Before we start the talk, let me discuss my objective for today is to discuss steps in diagnosis, management of the lesions with unusual clinical presentation. So they are not the easiest cases if they present to you. So I just wanted to start off with the 76-year-old male who came in into the school. I'm teaching at College of Dentistry in Lincoln, Nebraska for a long time. And this patient was seen a long time ago, and he came in with a scarf around his neck and head. And his wife told me that she brought him in because he couldn't wear his dentures. And as soon as I was walking into the clinic, I could smell a bad odor coming from him. So before opening the mouth, I thought he could be having some diabetic complication or some fungal infection. That was my thinking. But then as soon as I came and he opened the scarf and I saw the chin with a oozing lesion, I knew it had to be something more. Then I opened his mouth, and there it was in the floor of the mouth. There was this large nodule, vesicular verrucopapillary nodule in the floor of the mouth. And I think he would have had problems wearing the dentures for a longer time. Anyway, this was an easy case for me. I didn't do any further investigation. I said, yeah, you need to go and see the UNMC physicians, ENT and referred him there. And they did a huge, a long surgery and got him back to shape. But we will talk about lesions with unusual presentations. So this was a 75-year-old female who came in to the perio clinic, resident clinic in the school now for an anterior mandibular swelling from tooth number 22 to 28. So what I'm talking about is 22 is the canine, left canine, mandibular left canine extending to the mandibular right first premolar. And it was basically swelling both on the facial and the lingual aspect, and it was non-painful. And there were few ulcerations in the anterior mandible and a small area of the gingiva enlarged around tooth number 24. So this is all happening for a month and a half. But I had seen this woman about 3 months earlier in our dental hygiene clinic because she was a regular there and yeah, she had sensitivity on the teeth, on the mandibular anterior incisors, so she wanted some grafting done. So that was the reason why we wanted her to come and see the residency program. Anyway, she came in and this was her clinical appearance. And you can see there is ulcerations in the area of the canine, tooth number 22, and area around tooth number 27, and around tooth number 24 and 25, there were white plaques. So, and this other photograph will show you that there was a little expansion both buccally and lingually. And the white plaques were there. So they did a biopsy with a clinical diagnosis of squamous cell carcinoma, and we received the biopsy. And then on biopsy, I saw this ulceration and certain blue cells. And the cells were atypical, and there were some multinucleated giant cells here, and there are nuclei which are of different sizes and shapes, and they were atypical cells. And I thought this could be a lymphoma. That's why I sent the case to UNMC lymphoma people for further evaluation. And he did all the tests for CD5 to CD10, CD20, CD21, cycling D1, BCL6, everything was negative. This doctor who was taking care of this case, who was on service at that time, said he called me and said, "Nagni, find out more information about the patient," because we had no information on the past medical history and the medications. And basically, we didn't know the history of chief complaint, except it was there for a month and a half and there was no pain. And we didn't know about smoking or chewing history. But at least one thing was clear on that histology, that it was not squamous cell carcinoma. So the additional history was she had hypertension, diabetes, arthritis, and knee was replaced in 1997. So I was seeing her in 2007 or something. So 2006 actually. And the medications included medications for diabetes, hypertension, and arthritis. So she was taking Arava, prednisone, Remicade, and she was also on Zoloft, clonazepam, which would make her mouth dry. So there were quite a few medications that could result in this kind of a problem. Then, when I told my lymphoma doc who was working on this case, the medical history, he decided to do a GMS stain, and all the it lit up. The cells lit up with histoplasmosis. So these were the fungus, the bacilli oval areas are the histoplasmosis. So it was very easy now to call it histoplasmosis. The problem was in histoplasmosis, we are supposed to see a granuloma. And this histology of non-granulomatous atypical cells with few giant cells did not look like a granuloma, which kind of made us think of other diagnoses than histoplasmosis. So this was a case of histoplasmosis. So once we knew that this patient got Sporonox, which was given to her IV in the hospital, and she became better. The other information I haven't told you is that she had developed cough before she had lesions in the mouth. So they had done sputum studies which were negative for fungus. So this was a good case, and we reported this case because it was unusual because tumor necrosis factor antagonist, the infliximab, which is called Remicade, is a monoclonal antibody used to treat rheumatoid arthritis. So this was in 2006. It was coming up at that time, and it resulted in an atypical histological appearance, which was diagnosed as histoplasmosis. And this was a unique case, and it was reported we reported this case as such. And so this is the first reported case of infliximab in associated oral histoplasmosis. And histoplasmosis is common in the Midwest, especially in endemic areas, and it is very common here. So, and if I knew infliximab would result in that kind of an unusual histological finding, we would do GMS, and it was an easy diagnosis at that time. So this was a difficult, very interesting case. Now coming to the next case, this is a 75-year-old female who was referred to me from her rheumatologist for sores in the mouth. And it was there for 4 months. And the ENT had treated her with antiviral, antibacterial, antifungal. And then finally they gave her steroid. Then mouth felt better. She had lost 17 pounds but she gained back 7 pounds when she was on steroids. But they stopped the steroids. Now lesions came back, and then they thought maybe she has Behçet's disease, and she had some skin lesions which would come and go on her right arm. So her past medical history was positive for arthritis, trigger fingers, osteopenia, high cholesterol, and kidney stones. So these were her medications. So basically, she was taking Zetia for a high cholesterol, simvastatin for high cholesterol, and fexofenadine for pain, and metamucil, which was for her um, uh, for moving her balls. So she had no known drug allergies. She had quit smoking in 1980, and she had smoked about 7 to 8 years when she was in college. She had occasional drinks, but she was not drinking at this time because the mouth was very painful. So this was her appearance. So you can see bilateral ulcerations with white striae. And when I saw this, I thought, good, she has lichen planus. And she had white plaques and ulcerations on the dorsal tongue and on the lateral tongue. So there were lesions everywhere in her mouth. In the palate, you can see on the marginal gingiva is red with white lines, striae, and red areas, and then red areas on the gingiva and the facial as well. So she had mouth full of sores, tongue, everything was ulcerated and hurting her. She couldn't eat properly. So I thought she had lichen planus. So that is a very good, easy diagnosis, I thought, and we did a biopsy. And the biopsy showed hyperkeratinization with area showing lymphocytes, and it was hugging the epithelium, so subepithelial band. So I was thinking, yeah, it can go in with lichen planus. And you see the higher magnification, and you can see some lymphocytes getting into the epithelium. So this is again a high power view, another one, but shows less number of lymphocytes, and there are mainly lymphocytes in the area. And I started doing direct immunofluorescence on all my patients about 10 years ago. So on this patient, I did a biopsy, which I placed in Michelle solution and sent it off for direct immunofluorescence. And it showed nuclear IgG in a speckled pattern and weak staining of IgG in the cytoplasm in a dust-like pattern. So then, according to the considering the DIF finding, it was called systemic connective tissue disorder, most likely lupus. So imagine my surprise. I thought it would be lichen planus, but you have to think of other things in the box and not jump to the conclusion. And if you had not done a biopsy, we would have gone down the wrong path. So anyway, she was diagnosed with connective tissue disorder, likely lupus. So she was being seen by her rheumatologist, who started her on methotrexate 2.5 milligrams multiplied by 6. So she was taking about 15 milligrams of methotrexate once a week, hydroxychloroquine, and prednisolone, and I gave her prednisone for 7 days. So at that time, initially, I just gave her prednisone and prednisolone. And this is at her, I saw her many times, and this was the last appointment about 3 years into the 3 years from the beginning. So she was so much better, but this was her last appointment with me, and you can see her mouth is feeling better. She had no sores in the mouth, and if she started anything, she would use the prednisolone and it would become better. So this is a case which prompts you, though clinically it is so very clear that it had the white lines and ulcerations, looked like lichen planus, was not lichen planus, and she needed to be treated with methotrexate and hydroxychloroquine. So this is an unusual case. Now coming to another 80-year-old female whom I saw for painful lesions, sores in the mouth, and they were there for 3 months. And for these sores were all treated with laser, Valtrex, and nystatin. Nowadays, most of our dentists are using laser for treating every disease. So they did laser, and all these sores had started following her knee surgery. And she had a history of rheumatoid arthritis. And she was on prednisone, folic acid, meloxicam, furosemide, minocycline, and gabapentin. She had discontinued Boniva, and Fosamax. So those were the medications she had used, the bisphosphonates, which had been discontinued about 5 years ago. This was her oral finding. You see the pus pockets or purulus that was found on the teeth. And they were on the gingiva all over. And this was on the right side, and on the left side too. Again, you see multiple abscesses and like gingival abscesses along with areas which was exposed bone. So she had multiple mandibular lobulated tori, and you can see the abscesses again. And these teeth were all, they had some root canals and crowns, and this is the palatal tori, and it had the bluish discoloration, and the mandibular gingiva and the exostoses. So she had multiple exostoses all along the maxilla. So you can see the exostoses which were bluish in color, and look at all the teeth. So here there was no abscesses in this area. So even her nails were discolored. This discoloration is most likely due to her minocycline therapy. So because she was on minocycline for a long time, that had resulted in discoloration. So this is her radiograph, you can see X-rays showing um, uh, no periapical lesion, and all you can't look at the pano and say um, the lamina dura and all that, they are all intact, but you can see there is perforation in the bone along with sequestrum being there. And so that is the radio opacity that is present. Again, more area of radiolucent perforations both sides of the jaw with radio opacity showing fragments of bone. So to summarize, increased bone density at different areas, lamina dura and the socket margins were radiodense, mottled appearance showing progression from osteolysis to focal diffuse mixed radiolucent radiodense areas, and there were some areas which were getting sequestered. So we thought a diagnosis of MRONJ. And because she was in pain, and this is how they classify MRONJ, depending on the pain and the presence of the lesion. And because she was in pain, we decided she was in stage 2, needed antibiotics and antibacterial therapy. So based on this, we put her on PenVK 3 times daily, 500 milligram 3 times daily for 3 months, and she was on Peridex twice a day for 3 months. This is 3 months follow-up. She was becoming better, and you can see all the abscesses have healed, and the bone was being thrown out. So there is sequestration of the bone, and so there is healing taking place, and you can say the whole area is healed, but there is gingival recession and areas have healed. Along with that, you can see the amount of discoloration on the teeth because of the chlorhexidine which she was using for 4 months. So this is her following treatment. So this is a case of MRONJ which was being treated with Valtrex and nystatin and laser therapy before I saw her, but we didn't do any other periodontal surgery or anything because we thought maybe she will need to see the periodontist, but she became better and the bone sequestered out and she healed with no other complications. And this is her again. You can see how she's healed, but she does have the torides and the exostoses. They all remain the same. Thank you for giving me this opportunity to share my cases with you. Any questions, you can please ask, send an email to nnarayana@unmc.edu. Thank you.
Thank you, Dr. Narayana, for a very intriguing and informative presentation. And thank you all for watching. If you like the lecture, please let Dr. Narayana know by liking, commenting, and sharing it. In the announcements of our coming events, first, let me invite you to the second anniversary celebration of Oral Pathology India and Oral Pathology 360 on the 27th of August. On this occasion, we are bringing you an oral cancer update webinar along with the Vaidehi Institute of Dental Sciences and Research Center Bangalore and Goa Dental College. We have 2 lectures by field experts and a quiz organized by GDC Goa. The winner of the quiz will get a chance to present a short lecture on the channel. All registered attendees who attend the webinar on the Zoom platform or YouTube live stream will receive a certificate with 3 CDE points. Registration is free but essential for receiving the certificates. You will receive additional details and instructions via email on the 27th. Please complete your registration and find details, including the time in your own zone, on our website, oralpathology360.com. Beyond the anniversary celebrations, our weekly programs will go on. And coming Tuesday, we have a presentation from Central America. Dr. Roberto will discuss oral epithelial dysplasia using a case based approach. And with that, I will say bye for now. Hope to see you on Saturday. Have a great week.